Welcome, everyone. Thank you again for joining us for our first fall session this year in the Canadian Breast Cancer Network's Questions and Experts series. I'm Jen Gordon, and I'm the Director of Operations with the Canadian Breast Cancer Network, and I'm pleased to welcome you to our session today. For those of you who may be interested in previously recorded sessions, I'll put a link in the chat where you'll actually be able to see where you can access those. And we will be continuing to hold questions and expert sessions throughout the fall and into next year, with our next one being October 7th, and we're going to have a drug access navigator join us. So if you'd like to be notified and reminded of these sessions as well, I'll put a link in the chat also, where you'll then be able to access the registration for these sessions and also to be notified of them. So I'd like to extend our sincere appreciation to our sponsors for today's event. Our gold level sponsor is Viatris. Our silver level sponsors are Novartis Oncology and Roche, and our bronze level sponsors are AstraZeneca, Knight Therapeutics, the Ontario Trillium Foundation, and Pfizer Oncology. So we will be taking questions throughout the session. The way you can submit those is by using the Q&A box on the bottom of your screen. Also, if you're not able to see that, feel free to use the chat if the Q&A is not accessible to you. And we will be taking questions throughout the session, and Dr. Seely will be answering them. We have had some submitted in advance, so we will start with those. And I would now like to welcome Kathy Amanda Lea, who is the chair of the board of the Canadian Breast Cancer Network. She will be our host for this session. And as someone who has personally experienced a breast cancer diagnosis, Kathy really understands the many questions that come with this diagnosis. So she's going to lead us through this session. And Kathy, over to you.
Thanks, Jen. Welcome back to everyone, or if it's your first time joining us, welcome to another session of Questions and Experts presented by the Canadian Breast Cancer Network. I'm very pleased to introduce Dr. Seely, who is a naturopathic doctor and the founder and CEO of the Center for Health Innovation. Dr. Seely is also the executive director at Patterson Institute for Integrative Oncology Research, a professor at the University of Ottawa, a researcher at the Ottawa Hospital Research Institute, president of the Oncology Association of Naturopathic Physicians, and fellow to the American Board of Naturopathic Oncology. I've had the pleasure of hearing Dr. Seely speak at several patient education sessions and look forward to the insights and information that he will share with us today. Dr. Seely, welcome, and thank you for joining us today.
Thank you so much. Yeah.
You're welcome. Okay, so let's get started. As Jen has mentioned, we have had submitted questions, and we'll start with some of those, and then Jen will go with live question as we continue along our conversation. So one of the questions was, are naturopathic doctors in Ontario able to prescribe medications?
Yeah, so the role of NDs in terms of medications is a little bit, it depends on the jurisdiction. So in Ontario, the NDs are able to prescribe certain natural therapies at certain doses and use injectable therapies that are considered more natural. So we can use bioidentical hormones to some degree, and also high doses of vitamin D. But by and large, the prescription medications that you'd normally be able to receive from a medical doctor or a nurse practitioner are not those that an ND in Ontario can prescribe. So in BC, the jurisdiction and the regulations are quite different there, which allows for a much broader scope in terms of being able to prescribe antibiotics and other prescription medications. So in Ontario, it is limited, but there are a few that sort of categorize as prescribable by NDs. That is dependent on the naturopathic doctor actually having completed a prescribing exam to enable that to be possible.
And then on that question as well, do you coordinate with the oncologist when you are prescribing any drugs?
So the drugs that an ND, really, they're not the same drugs at all that an oncologist would ever prescribe. So it's quite a different scope of practice as it intersects with cancer care. So you'd never get, tamoxifen is not something that an ND would be able to prescribe, for example, and certainly not chemotherapies either. So in terms of the communication between the naturopathic doctor or the complementary practitioner and the oncologist, it does depend really on the relationship that may exist between the two clinicians, and whether or not there's a pathway for that communication. Some cases there's going to be letters that may be sent as far as communication goes, or simply being able to receive the medical documents from the hospital related to the care of the patient, which, so ideally integrative medicine is a communication and a discussion and a sort of a more coordinated approach. But the reality is that doesn't usually translate. So often the care that a naturopathic doctor is going to be providing in the community is not coordinated closely with the oncologist. Now, the ND should be aware of what each patient is receiving as far as that care, and be able to tailor the recommendations accordingly and safely. But it's infrequent where you get a very close communication between clinicians.
Okay, thank you very much. Jen, you have a live question now?
Yeah, actually, this ties in really nicely with what you were just speaking to, Dr. Seely. So you were speaking about that coordinated approach that doesn't necessarily always happen, but that is oftentimes communication, or can be communication, between the oncologist and the naturopathic doctor. But what can a patient do if your oncologist simply refuses all options for complementary medicine, or is not willing to have those conversations? How can a patient navigate that?
Yeah, it's a tough issue to navigate for sure, because the patient's in a position where, one of their most trusted clinicians, their oncologist, who's going to be providing pretty, in some cases, toxic therapy and very important for their care, is telling them not to do anything outside of that. And in some cases, the person, the woman or the man, is going to be very interested in using some of these natural therapies and feels like there is a real role. And from my perspective, I think there absolutely is a real role for many of these therapies. But when you get the oncologist that is really adamantly against it, it's difficult. So I think it's always important to be, provide the information to the oncologist, to the clinician, whomever you're seeing, about the therapies that you're doing, so that they can address it at least, and to try to open up the discussion. And so, for someone that's just very, very resistant, it can be difficult. I think coming with a preset set of questions, or even saying, listen, I know that you have some concerns about this. Would you consider having the pharmacist as part of your team review some of the therapies that my naturopathic doctor has recommended? Are there certain therapies that you'd be open to? That kind of thing. Ultimately, it's the person's choice. So I think that's always important to know. It's not, you cannot be dictated to as far as what you're going to receive or not receive. But ideally, you want to be able to do the therapy in a way that you feel, yeah, it's not going to interfere. It's not going to cause any problems, and to enable that a more open discussion is going to be helpful. I think we're seeing a shift in terms of the perspective of many oncologists, that they're more open to an approach that includes complementary medicine, because the reality is, a significant majority of people are using complementary medicine alongside conventional care. So to bury one's head in the sand and just say, don't do anything, that doesn't really empower the patient. And often it just leads them to do things without any discussion. So I think we're seeing a shift in that, but ideally, sometimes you can sort of go around maybe the oncologist a little bit, or try to open up a discussion in a good way. Always being respectful, I think, of the person, and ideally that's reciprocated, but being respectful of their position, but being persistent. Everyone has the right to bring these questions forward and to discuss it. It's not, yeah.
Yes, thank you. Thank you. That's very good. I have another question that was submitted. What medications do naturopathic doctors suggest for breast cancer patients whose sleep has been, she says, stolen, I would say compromised, by drugs like tamoxifen?
Yeah, so I mean, the issue of sleep and sleep hygiene and sleep quality and disturbances is a difficult one, because there's many reasons why sleep can be affected negatively. There can be anxiety, there can be hot flashes, There can be distortions in GI function or the need to urinate more frequently. There's a lot of reasons why sleep. Pain is another one. So looking at what is bringing on the negative effects on sleep is important, and trying to determine what the cause is for that, and then addressing that particular issue often leads to sleep being improved. So, there are certain therapies, in tamoxifen in particular, that can support the reduction of hot flashes. So, some options include things like rhubarb extract, as an example, which can be helpful. There's also black cohosh, there's acupuncture. There are tools that can be used to help reduce hot flashes without stopping the effectiveness of tamoxifen. So I think that's important. Not every therapy, though. Like, there are certain therapies that do interact with, but there are options that a practitioner who understands the field can recommend that's not going to interfere with that. So, that's the hot flashes particular picture. If it's anxiety related, then addressing the anxiety and what's creating that, and giving outlets for that can be very helpful as well. And there are natural therapies that can be supportive in that. There is counseling that can be supportive in that. There is just eliminating the mystery of treatment and understanding what's at stake that can help with relieving anxiety. It can be maybe even just working on relationships that are creating that anxiety. So there's a multitude of possibilities that can be creating that sleep disharmony. So that's how I would approach it with someone who's dealing with that, to try to figure out what's at root cause, what's going on, and it can be multifactorial in many cases too. So there's no easy solution, and it can be difficult for some, but often we get very good results with sleep hygiene.
Right, and I would imagine that if somebody comes with comorbidities, they're also taking other medications, and that would also complicate the entire, process of taking complementary,
Yeah, it can. Yeah. So in terms of interactions, the potential becomes, you've got to look at the regime of medications that a person is taking and what's causing that. Someone who's taking prednisone, for example, is really going to have an effect on their sleep, but you don't want to stop that necessarily either. So, some of these things can be time dependent. But an exploration often leads to some improvement.
Yes. And
sorry, Kathy, just to jump in while we're on this topic, because you'd mentioned practitioners who understand this field in particular, or really other types of like comorbidities and other types of treatments. Can you just speak to maybe how can a patient go about finding a naturopathic doctor who has an expertise in oncology? So who does really understand the field? How do you go about sourcing that within your community? Because there's lots of naturopathic doctors, thankfully, but are all of them experts in the oncology space? And if not, how do you find someone who's familiar with that?
Right. So I guess I've got a couple of biases to sort of state before I respond. I think naturopathic doctors are incredibly well equipped to be able to provide care for patients with cancer and other chronic diseases, because NDs have a 4-year curriculum of education, full-time, post-grad. There's licensing exams. There is a regulatory body that oversees our practice in Ontario, not in other, like Quebec is a totally different kettle of fish. But in Ontario, at least, there's a good regulatory framework, and continuing education, accountability, all those things are built in to the practice. And in other places like BC, as well as Saskatchewan, Alberta, there are these regulations, Nova Scotia as well, to some degree. So looking to see, first of all, for an ND, that they are coming from an accredited naturopathic college, which is the Canadian College of Naturopathic Medicine, now includes Boucher Institute in Vancouver as well, which are those accredited programs. Outside of that, within the naturopathic sphere, I would also look at the Oncology Association of Naturopathic Physicians, which is the oncanp.org is the website. And that identifies members across Canada and the United States that have a focused practice on cancer care. And so, there's more education, there's conferences for that. that we do to enable our practice to be better informed and safer and more effective. And so I think though it really depends on that practitioner, but the ONC-ANP and the ND I think are good criteria to look at. And then there's also the fellow to the American Board of Naturopathic Oncology, which is an additional designation which you can look up on the website, which requires testing and further education around that. So that's, I think, important. And then when you're looking at other practitioners, perhaps in acupuncture or massage or osteopathy, I think looking to, if they are coming from a regulated profession, that's helpful because there is accountability for it, for their practice. Whereas those that don't come from accredited, regulated health professions can be very good in some cases, but there's a larger diversity of quality in that case, because you don't have accountability, and what they and how they represent themselves can be very distorted from reality. So I think that's something to look at, looking at the information on their website, looking at the information and how they present themselves to you in terms of the patient and what to expect is really important. So, they should be able to give you full answers about what is the goal of treatment. What are they trying to achieve? Is it matching what you're hoping to achieve? And then what is the level of evidence related to that? And what is the safety of it? And what are the costs? It's really important to know what the long-term and short-term costs are going to be for the therapies, because in some cases, these therapies can be very inexpensive and easily done at home, things like nutrition. And in others, it can add up a lot. So you really want to know what you're getting involved with. And I think those questions should be addressed, and you should not have any sense of discomfort, and never a sense of, I've heard of practitioners who sort of put the fear of God into their patients, that if they don't do a particular thing, they're going to have a bad outcome. That's horrible practice. Like, it should never be done. And that's on the conventional oncology front, or on the complementary side as well. You should never be feeling that if you don't do something, you're putting yourself at risk. And I think that's really important. So you want to feel very comfortable, very trusting of the relationship, and have the full spectrum of understanding. And really, you're interviewing them as well in that first visit. So before you decide on doing things, I think that's important. So yeah, I mean, lots of in there, but like looking at the regulations, looking at credentials, looking at education, and then really your interaction with that practitioner is super important.
That's great. Those are some great resources. Thank you.
And the benefit
the
benefit with complementary practitioners is you totally have the choice, right? You vote with your feet and your wallet in that way. Unfortunately, we don't have that same level of access in the conventional world. Anyways, yeah.
I was just going to add to this. Is there, in your opinion or in your work, do you see the practitioners have developed a standardized care that you all discuss, and you all sort of like evidence-based medicine? Is there a standardized care that is followed by yourself and your colleagues?
It's a great question, and it's one that we discuss a lot at the ONC-ANP, the Oncology Association of Naturopathic Physicians, because we're trying to promote the care to improve, as well as the level of care that's being delivered by the clinicians in the membership. And so we wrote a guidelines, principles of care document that was published not long ago in the journal Current Oncology, which actually goes out to the oncologists across Canada. It's a peer-reviewed journal, and that established the mechanisms, the things that NDs, who are naturopaths that are treating people with cancer, should be focused on, and what they should do in terms of communication, the things to look out for in terms of risks and care, all of that. And so that's been published, like I said, in Current Oncology. That publication is open access as well, and I'll see if I can put the link up directly. I can probably find it and bring it up. But yeah, so that's something there. There's also, we have something called the Knowledge in Naturopathic Oncology website, which is now the Knowledge in Integrative Oncology, I should say. which provides evidence summaries on the different therapies that we would use, and it's a resource that we can go to. And there's lots of other resources that are out there that are well recognized and well cited.
Thank you. That's helpful. I have one last drug question from a patient who asks about the metformin drug. Is that a recommendation from somebody like yourself in prevention of cancer recurrence?
Yeah, metformin is interesting. It works as on a particular pathway in cancer cells that are triggered as mTOR, or the mammalian target of rapamycin, but it's which is a targeted therapy that's been sought after by many prescription patented medications. Metformin is a drug that's used for diabetics to control blood sugar. And it also happens to have this ability to target mTOR. And there is some evidence, particularly in ovarian cancer, that it may potentially be a useful agent in terms of prevention of recurrence. And so for those patients of mine that are diabetics that are using metformin, I'm like, great, you're taking this. There is things like, berberine as well, which has similar effects in some ways, but not quite the same level of evidence. I would put metformin in the category of very interesting and possibly useful. And if there's no side effects from it, then I don't think it's a harm to take. You're not going to get many GPs and oncologists that are going to recommend this and prescribe it for that reason. It's been studied, and I think the science is developing. But yeah, it's one that I think we'll see maybe more of in the future.
So input.
Sorry, you're just getting frozen there.
Yes.
I think
Jen?
we have you back, Kathy. Start over. We lost you for half of that. Nope.
No.
You may have frozen again. So why don't we'll move on to one of the live questions and then come back to Kathy, and hopefully her internet will reconnect. So someone is asking about the type of natural resources that are available to reduce the side effects of radiation during and after treatments. So some of the natural therapies they could take. Sorry, Kathy, you were frozen. We moved on to a live question and we'll come back to you.
That's fine.
So this is a tough question because I think there are therapies that can be useful. I'm very cautious about making recommendations for things that people are going to jump on to use. I know there's a lot of safety around these in many cases, but also there can be cases where it's not best to use. So, things like curcumin, berberine, vitamin D, melatonin, all have some potential utilization with radiation, vitamin E as well at low enough doses to reduce radiation fibrosis, for example. But I think it's important to do so with knowledge and with the guidance of someone who is able to look at all the different medications that are being taken. What's the purpose of the radiation? Is there any potential to interfere with the radiation with the therapy or not? And so I avoid high dose antioxidants with radiation therapy because I think it can potentially interfere with the effectiveness, and we don't want to do that. That said, there are some antioxidants that actually have some evidence for benefit in certain scenarios. So I'll use it in those cases, but trying to sort of using a more precautionary principle and not wanting to negatively interfere, obviously, with the therapy. And we need more science on it for sure. But yeah, I think there are things that can be done that can help with radiation and to potentially augment the effectiveness of the radiation, not just reduce its side effects.
Thank you. I have another question that was submitted. The question is, with the complexity of each type of breast cancer, how can I be sure that supplements given to me by my naturopath are adequate and compatible with the regular meds given to me by my oncologist? So it's somewhere where we've already touched a little bit on. So maybe you can just give us a little quick overview on this.
So I sort of categorize interactions with medications in two ways. One is as a pharmacodynamic interaction, and the other is pharmacokinetic interaction. The pharmacodynamic interaction is where you've got two therapies that are stopping each other from working some way. So in some cases, radiation therapy and high dose antioxidants, you may be quenching the effectiveness of the radiation. And so that would be pharmacodynamic, although it's not a drug. But a chemotherapy might act in the same way. The pharmacokinetic interaction is, and sorry, just on that too, pharmacodynamic can be positive. You can get a synergy that's more effective and it doesn't quench. Whereas you can get, so it really depends on what you're trying to achieve. And then the pharmacokinetic is where you change the metabolism of the drug. And so the speed at which it's eliminated from the body is changed. And so that is an interaction which usually is never positive, because once you change the profile of its elimination, you kind of get into territory where you don't know what's going to happen. Either it goes too high in the body and gets toxic, or it gets too low in the body and becomes ineffective. So so I don't like pharmacokinetic interactions because they're almost always not good, because you just change the level of medication, and then the pharmacist or the oncologist needs to potentially change the medication dose, which is not going to happen so much. And so there are cases, and so pharmacokinetic interactions happen when the metabolizing enzymes that are in the liver predominantly are affected, and that can change the elimination of these drugs, and or maybe through the kidneys or through the colon, whatever pathway that they're eliminated through. So I think knowledge by the CAM practitioner, and I think in this space, you're really your practitioner that is knowledgeable in this area is the naturopathic doctor, or a functional integrative medical doctor, or potentially an integrative pharmacist who can really, and pharmacists are good in this area because they know this area well. But the ND, the naturopaths, are going to know those medications that are usable in this space, and they should be knowledgeable around the ways in which they're metabolized. In cases where I have no idea, there's no evidence for it, I stay away from. But there's certain therapies that we know we've used, and there's evidence for no interaction, and there's evidence for benefit. Then those are the ones that I use. But it's and that science is changing. So I think you need someone to be relatively current and aware and knowledgeable. Tamoxifen, for example, I don't use now with curcumin with high dose, because there is some potential for curcumin that's evidence that actually reduces tamoxifen metabolites.
Okay. I have another question that asks, what would you recommend for treating radiation fibrosis?
What would I use for radiation fibrosis? I mentioned the other ones earlier. As far as prevention, I think there's therapies to use in conjunction that may be useful. And then post-treatment, it's difficult. It's difficult to reverse that, but there are some potentially, proteolytic enzymes. There's the possibility of antioxidants in that therapy, and breathing exercises, and just, sort of a healthy foundation. There's nothing that stands out that I have that's a really key evidence-based one. Hyperbaric oxygen is being considered for it as well, possibly. I'm not convinced that's the case. Using oxygen in cancer care directly, I think, has not, at this point, has a strong basis in evidence.
So I do have a question related to what you just said about the hyperbaric oxygen therapy. And that question is also regarding the benefits to post-radiation cancer patients. So can you elaborate a little bit on that?
Yeah, so I mean, hyperbaric oxygen, you're basically trying to push a degree of oxygen concentration into the blood People use it for cancer control to some degree and as an oxidative therapy, with the idea that if you can oxygenate the tumor more effectively, then you're going to stop its growth. The problem is oxygen is kind of a toxic metabolite in the blood. It's fast. It's removed quickly. I actually think as far as oxidative therapies go, the use of intravenous vitamin C is a more effective oxidative therapy because you create an oxygen intensity around the cancer cells through the ascorbic acid, but you're not actually doing it through the oxygen in the blood itself because it's just quenched quickly. I haven't seen anything that really convinces me of the use of hyperbaric oxygen. I know some colleagues would argue with me that may not be the case, but it's not something I've explored extensively as being beneficial.
How often would you get a question around this from a patient that you see?
I don't get the question too often. I get it on occasion. I think that there is, it's rather intensive, and I just the ability to find a good location for hyperbaric oxygen is one thing too, where you can get a high enough concentration. You need a chamber that's basically a steel chamber. You can get inflatable ones that are lower, create a lower pressurized capacity. I think if it's really beneficial, you need a much higher pressure, but there's just not enough studies for me within the context of everything else available to suggest this is a useful one. I'd rather someone would go for the use of hyperthermia treatment, for example, which is high heat in conjunction with either radiation or chemotherapy. Also a more costly therapy, but there is more evidence for the use of that in that scenario.
Oh, well, thank you. I'm sure you'll get questions around that, or somebody's going to explore that a lot further. Jen, do you have live questions?
I do. We have just one quick follow-up question, and then I'll go to another question. Someone asking whether or not if metformin is being prescribed by NDs in BC. I know you're in Ontario, but
I think it is. I think it's probably likely, yeah.
Okay, and then moving on to go ahead.
Well, our nurse practitioner will prescribe it on occasion where there's an indication and potential benefit as well, but our NDs can't. But yeah, in BC, I think they would and can in some cases.
Okay. And then on a different topic, any recommendations for people suffering from lymphedema following breast cancer treatment? So this person is referencing particularly node dissection and radiation, but anything you can recommend for that?
Yeah, so lymphedema is one that occurs in some cases where there's been a full axillary typical removal of the lymph nodes. Probably everyone's aware of that, but so the swelling can develop because the lymphatic fluid is not readily sort of pulled out of the arms. And the lymphatic system is not a circulatory system. It doesn't circulate. It is more like little tributaries pull the fluid out of the tissue limb, and then it feeds back into the blood vessels at certain locations. So the lymph nodes can act as dams, not so much dams, but more sort of the points of conduit and collection of lymphatic fluid, where there's an exposure to the immune system to the lymphatic fluid as well. And when these nodes are removed, it can cause blockage in the return flow of the lymph from the appendages. So most commonly in breast cancer, obviously with the number of axillary or under the armpit lymph nodes removed, then you've got less of these pathways or tributaries through which the lymph can flow. And so people can get lymphedema, which is essentially a swelling of the arm as a result of that. You can get lymphedema in the leg. It's not only arm dependent, but it's where those lymph nodes typically have been removed or possibly damaged by radiation. But surgery is often the cause. So in terms of its management, looking out for it, is one of the first things. Prevention is easier than treatment. And so being mindful of, the arm that has had the surgery on the same side with the nodes being removed, maybe if you've got a ring on that finger, noticing if it's tight, it's a first sign. Possibly you even just take a measurement with your, you can measure it around the wrist, feel if there's any swelling there, obviously visually as well, but it can creep up and then it can move more quickly. In terms of things to avoid, often the idea of, before it was an idea of avoiding any repetitive exercise. I think that's kind of been debunked. It's not, doing exercise is supportive for lymphedema management and even prevention and just overall health. There's nothing better than exercise, really. Well, exercise is very, very important for, prevention of recurrence. So I always recommending people don't stop exercise, but soon after surgery, being careful with the arm, not repetitive movements perhaps at that time, not doing in like the time of healing things like saunas or things that are going to really intensify the heat. I don't think people need to avoid saunas for life or hot tubs for life, but I think it can creep up and develop even months or even years afterwards. So it's something to be aware of. If there is a development of lymphedema, compression garments are really the most effective tool at reducing that. And you can do things like lymphatic massage, and that can be helpful as well. And which is sort of a light drainage kind of massage where you're helping to push the lymphatic fluid, but that's not for more severe lymphedema. If there is lymphedema, watching out for things like cellulitis, which is where you get an infection of the skin, is important. So good hygiene is really important. There are cases potentially where the use of things like proteolytic enzymes might have a role. And looking at range of motion, massage is helpful, physio is helpful. These things to keep the tissue supple are important as well. I saw a question in the chat which was focused on the it was on a question on mistletoe. Where is it? I've lost it now.
It's around, I've got it here in the Q&A if you'd like me to just read through it. Recently started mistletoe injections, and she's a stage 4 metastatic breast cancer patient. How does she sort of summarize the benefits of that in terms of quality of life to communicate that to her oncologist? And maybe even listing some of the benefits of that for anyone else who's interested in learning a little bit more about mistletoe injections.
Yeah, mistletoe is an interesting one, and I think actually we've got a decent amount of evidence with respect to this therapy, more than many complementary therapies, especially in breast cancer and with chemotherapy. There are at least 4 randomized controlled trials that look at the use of mistletoe in conjunction with chemotherapy, and the outcomes related to quality of life, side effect management are better with those. So the addition improves outcomes with respect to quality of life and symptom management. And that's been shown. There's been some studies looking at the metabolism of chemotherapy with the use of mistletoe, which also show no negative effect as well. So the argument that this is going to negatively interfere with chemotherapy, I think, has been disproven. And the other one, which is, the key part of it is the potential for mistletoe therapy to actually reduce the risk of recurrence. I think there is some evidence for that. It's not as strong as the quality of life impact with chemotherapy, but all of the evidence that exists is supportive of a positive effect with respect to longer term outcomes in the cancer area. And mistletoe is usually given as an injectable therapy, most often subcutaneously, which is just underneath the skin. And it is done in a way that is done typically 3 times a week, and you gradually increase the dose over time. And there's a few side effects, but they're relatively mild and manageable. in terms of just localized reddening of the tissue and that. But I think this is a therapy that we're going to see more of, and with more clinical trials, especially in terms of longer term outcomes. But we use it. I'll use it, and I do find that it can help with side effects related to chemotherapy, and that's consistent with the evidence.
I have two follow-up questions on that very quickly.
Yeah.
One is, my question is, any chemotherapy, all chemotherapies, or?
Chemotherapies, yes, by and large, there's going to be very few interactions. Immunotherapy, which is, I would categorize as something different, there's not as much evidence in that area. There is some study with the combination, but nowhere near as much as with the more sort of standard cytotoxic chemotherapies.
Okay.
So yeah, and the realm changes, right? There's more targeted therapies, all of that for sure.
That's right. That's
Yeah.
right. And the next question would be around how do you differentiate side effects when you're doing combinations like this? Say someone gets a side effect, how do you know if it's the mistletoe or the side effect of the drug?
Good question. I think we know the side effects, and the patient knows often what the side effects are related to. And it's, you can like the typical side effects related to chemotherapy, things like neuropathy or mucositis or nausea, fatigue, the depletion of the bone marrow and the blood, the white blood cells, or platelets. Like these things are you can pretty much identify with the chemotherapy. If someone feels a little bit sort of feverish, or if they get a redness typically around the site of the injection, or potentially a sense of fatigue or malaise after the injection, that I will see is more related to the mistletoe. But the frequency of the therapy is higher with the mistletoe, and I'm pretty confident to be able to distinguish between the two in that way. In few cases, people would be stopped from taking it based on those side effects, where the reaction is just super pronounced. The one consideration and concern around it is where you get a body temperature elevation with the mistletoe, because people would be concerned that maybe it's their neutropenia and they've got an infection and they need to go into the hospital because of that, because you can get a slight change and increase in temperature from the mistletoe. That temperature increase is usually moderate and small, and not the same degree that you'd see with someone who's got an infection. So if someone was over a 38 point, whatever, 38, consistently over a 38 degree temperature, go into the emerge. It's probably infection related. But a transient half a degree temperature change would be more likely mistletoe related.
I know Jen has a couple more questions around that, but I have one small question. Do you consider skin testing for allergy before dosing patients with mistletoe?
We used to, when it came to the use of intravenous mistletoe therapy, which we use in in relatively rare cases for more advanced metastatic disease. But we don't anymore. Because we don't see those allergic reactions. There is like 1 or 2 reports in the literature of this happening, but that it's just so rare. So we don't see the need for it.
Okay, thank you. Jen, go ahead.
There's a follow-up question from John, who asked the initial question around mistletoe, asking if it's safe, if you would include targeted therapies in that safe to use with mistletoe. So for example, CDK4/6 inhibitors, would those be safe to use with mistletoe as well?
By and large, I would say yes. I think so. And it depends on the particular scenario for each patient. If they're managing well and the therapy is really effective, I probably wouldn't recommend it. It depends. It really does depend, but I don't see it as a contraindication, no.
And then you've mentioned, obviously, that it's supportive in helping symptom and side effect management. Are there certain side effects that it's more effective at managing, or is it sort of really helpful at improving all of the side effects from chemotherapy?
Yeah, it's a good question. I mean, the most studied one is a very global measure of quality of life,
Okay.
which sort of is a sense of how well the person feels. And there's a few scales that they look at. So that, just the tolerability of the chemotherapy and their degree of sensation of feeling sick and malaise and tired, those things I see is improved and is consistent with the literature. And in terms of things like also neutropenia and lymphopenia, lymphocytes, where the lymphocyte counts goes down a lot, which to me is more concerning on the immune front than neutropenia in some ways. Neutropenia is worrisome for infection development, and lymphopenia is more worrisome from the perspective of the cancer progressing. So I like to look at lymphocyte counts, and I see those change. I see those increase. I see those increase with other therapies too, but or not decrease as profoundly. And I've seen cases where patients are their own control and they start the therapy after, and there's less of a reduction.
Okay, so I have a question now around food myths and facts regarding foods to avoid, and I would also add to that foods that you can intensify on to like medication. Like if you if you take a blender of carrots, what's that going to do for you? So right. I'm not being funny, but that is some stuff that people are often misled, and it is dangerous from what I understand and from the literature that I have read. So the question is around the most common myths, facts regarding foods to avoid if you are diagnosed with ER and PR positive breast cancer. And maybe we can go through a short list, but I'm sure you have that as the number one question when you see patients. And on this list, I have dairy products, soy and soy-based products, flax and flax products, sugar, sesame seeds and sesame seeds products, beef, chicken, dark chocolate. I can't say that I've never heard of the beef and the chicken, but go ahead, Dr. Seely.
Okay, yeah, and you're right. People are very interested in this, and rightly so. And I think there are things that can be done that are subtle yet additive and beneficial in terms of quality of life and cancer-related progression. So, I don't think any particular diet's going to cure anyone of cancer. So I think, people that are trying to find the magic formula of foods and supplements that's going to cure them of their disease are gonna, it's a wild goose chase. There is no holy grail from that perspective. So, very, very constrained, very limited diets that are very prescriptive in terms of what you can do, I don't think are very helpful. And there's a lot of them out there, and there's a lot of particular thoughts around that. So, but with that in mind, the kind of principles that I talk to virtually every one of the people that I see around food, is by and large to have a diet that's more plant-based than animal-based. I think there's more benefit in there. There are some associations with red meat and inflammation. There's associations with just overall more fiber in the diet has been beneficial for the microbiome, which actually enables things like immunotherapy to potentially be more effective. But the things I like to focus on are positive foods, and so I talk about berries. I think berries are good. And by and large, especially organic, and they have compounds that are, considered bioflavonoids, whatever, that these polyphenols, these compounds that have subtle additive effects that give some signal to the cancer cells potentially to normalize and to, not be as malignant. It's not like there's an intelligence there, but there are these compounds that you get from spices and from fruits and vegetables. A variety is important, and I think that's useful. I tend to steer people away from lots of red meat because there's an inflammatory component to that. But if they're going to choose red meat, to go with grass-fed or organic is a better choice. You're going to get less omega-6s in those in the oils of the fat of those animals. Dairy is an interesting one, where we've seen more evidence that high consumption of dairy does lead to higher incidence of breast cancer and potentially progression. So I used to be more relaxed around dairy. I've become a little bit more, don't have an excessive amount of dairy. A little bit of cheese in the diet, a little bit of yogurt, especially, I think, is not harmful. And you do get some benefits from a very complete nutrient profile from dairy, things like calcium. But I think, heavy consumption of dairy is probably not a good choice. And again, you're working with people's habits and anxiety. And so I really never want to trigger someone to feel anxious about the foods they're having. And that if they can just avoid all of these foods, then they're going to be fine. Or, they really need to do that. Or if they don't, they're going to progress their cancer. So it's a discussion with a lot of context in that way. But so cruciferous vegetables, we've talked, cruciferous are things like kale, broccoli, Brussels sprouts, cauliflower. These foods have some compounds that actually may interact well with hormonal positive cancer, like the ER positive, estrogen receptor positive cancer, and just slightly alter the metabolism of estrogen in the body to a metabolite of estrogen that's a little less reactive. So I think that's good. The other one I would look at is flax, ground flax. I really like to promote ground flax for its effects, both in terms of fiber and ground, not just like the seeds, but actually freshly ground or pre-ground, but kept in a way that it's not going to go rancid in the fridge or freezer. And so there's that. Soy is another one that comes up, and I think was maybe you'd asked about, but soy has gotten maligned, I think, from like 1 or 2 studies done years ago, and there may be some more recent ones too, but the vast majority of evidence around soy is that it's protective, if anything. I don't think it's a strongly protective agent, but if I do think soy-based proteins, tofu, tempeh, edamame, miso paste, these are sources of soy that are good and probably better organic, although the whole GMO debate, I don't have a particular strong perspective on that one, but I think organic generally is better, especially for hormonally driven cancers, because pesticides we know can actually act as what's called xenoestrogens, or estrogens from outside. So xenophobia, anyway, so xeno comes from outside, whereas so xenoestrogens are these estrogen mimics that you get from pesticides, which actually can be potent. And they, I think, can contribute potentially, especially to the development early on, and possibly progression. So, it's, again, not to be like, if you don't have organic, it's good to eat fruits and vegetables, even if they're not from an organic source. But if you've got the means to choose organic, not a bad option to choose. Here I am talking about provoking anxiety. I'm talking about the bad things about pesticides, but anyway. So that's soy.
Let's do sugar. Let's do sugar.
Sugar, right. So remember we were talking about metformin before as, having an anti-glycemic effect. I think that's possibly one of the benefits of metformin, but in terms of diet, I am not, I do think that it's better to reduce the quantity of simple carbs and sugar in the diet. And the reason for that is twofold. One is that the sugar that you ingest is, especially in simple carbs or, sweetened foods, we're talking about pop, or actually orange juice is very sweet too. A piece of white bread, or any bread really that's not, sprouted or something like that. But these foods are quickly converted into sugar in the gut, and they're broken down. and then that's released into the blood. And so you get a blood sugar spike that happens from these foods, especially if you don't have things like fiber or fat or protein to cushion that effect. And that sugar spike leads to an insulin response, which pulls the sugar out of the blood in very simple terms. It's because sugar is toxic in high concentrations. And that's why diabetics are given things like metformin and or insulin potentially, because high sugar in the blood leads to toxic long-term effects. It makes your arteries more brittle. It makes it distorts proteins. It creates free radicals. It creates inflammation. So that from that standpoint, high sugar is pretty much bad for most chronic disease, diabetes, cardiovascular, and cancer. And so the high amount of sugar in the blood, though, is a fuel, an easily usable fuel by cancer cells. Cancer cells are notoriously inefficient in how they process energy. They go through a process whereby they essentially convert glucose into lactic acid, and they pull out a little bit of energy from it, but they do it very fast and they do it a lot. And so you get the lactic acidosis around the tumor, but you also get this inefficient energy production, and they're insatiable with that in that way. So a PET scan, for example, you're given a radioactively marked glucose, which goes to the tumors that are using the sugar most readily. And so, that's a pretty easy indication for people to see, yeah, my cancer cells are using sugar more, right? And so, so I think from the perspective of just reducing the amount of sugar that's in the diet, you reduce the level of the available easy fuel for the cancer cells. And you also reduce this insulin effect as well, which is almost like a hormonal driver for cancer cells. And for breast cancer, there is receptors for something called IGF-1, which is insulin-like growth factor 1. And and that is upregulated by an insulin response. And so that's another aspect of it too. You actually create more fuel, you've got a hormonal driver, and there's inflammation. And then there's all the other benefits of too much, of not having a lot of sugar. So again, going back to this anxiety piece, if you really like cheesecake on occasion, having a bit of cheesecake is not gonna totally change the pattern. Like have that, but maybe have it after you've had a Caesar salad, so that the salad reduces the glycemic effect of that cheesecake. Do you know what I mean? Rather than having a few cookies in the middle of the day, or that cheesecake in the middle of the day without anything, you're better off to have a smaller piece after a salad at dinner.
Right. Yeah. I have one more piece of food here, and it's dark chocolate, but I'll add wine, a glass of wine.
So there's good news, I think, on both of those fronts. So thank you for that.
I wanted to end it on a good note, right?
Right on. Yeah, I think dark chocolate in moderation is okay. It's not the super sweetened ones, and it doesn't have to be a particular over percentage for the cocoa level or whatever. Yeah, I mean, surprisingly, a Mars bar has a lower glycemic effect, meaning lower effect on blood sugar levels, than a slice of white bread. So, chocolate in moderation, particularly dark semi-sweet chocolate, would be something I'd say, yeah, have that. A great thing to have is if you like a little bit of chocolate, you can sprinkle a bit of chocolate, what are they? Chocolate chips in with some walnuts and almonds, great to have, and as a snack. And then you've got a little bit of sweet, and you've also got the benefits of the nut oils and the nuts as well. Red wine, or any wine, but red wine or red wine in particular has been studied, and it doesn't seem to elevate blood sugar very much. So I think, alcohol is another question, right? So the red wine, from the sugar standpoint, a little bit of red wine, especially with a meal, I don't think is going to be a problem from that standpoint. You'd probably have more of a problem with extremely sweet kombucha than you would with the red wine from that perspective. So, kombucha is a good drink, I think, in general, but looking at the sugar content is important too from that. But, but the alcohol content is a concern slightly. So, I don't think having 3 glasses plus of red wine makes sense as far as recurrence risk and incident cancer, because the more the alcohol content goes up, definitely there is an increased risk. But in the 1 to 2 glass zone, especially the 6 ounce or less, I think, you've got to gauge it in terms of quality of life and all of that too. So it's a personal choice. There is probably a slightly increased risk, but it's all a question of gradation, right? I mean, you walk out into the street and there's an increased risk of something. So it's you have to make those choices that feel right for you without limiting your life too much. And that's really important. So to be living empowered and not by fear by the diagnosis is really important. And there's so much in that, obviously.
So just one very loaded question. I think this is going to be a little bit of a loaded question. For those of us who are not disciplined and need direction, sort of like somebody who wants to go to a dietitian and they provide for them, here's what you're going to eat to benefit for either your weight loss or whatever you're going there for. Do NDs provide such recommendations or plans, I would say? Plans on?
Yeah, absolutely. Okay. I think, as far as, dietitians are extremely knowledgeable in macronutrient needs in particular, and our guidance for nutrient use in the hospital in particular. You don't find many community-based dietitians giving sort of meal plans, but you can around some of the issues related to their care. So for diarrhea or constipation, you're going to get some recommendations, or for the potential for blockage. It's probably more of a risk with ovarian or other types of cancer or colorectal. But so you've got your dietitians. Nutritionists come in varying levels of training, I would say, in terms of the degree of knowledge that they have, but they're probably more in line with a naturopathic doctor in terms of the kinds of recommendations they might make. And NDs are absolutely knowledgeable in nutrition. So yes, you should get good guidance on nutrition from an ND. And you can ask for that, and many of my patients, I'm more focused on their nutrition than perhaps, other things like it depends. It really depends on where their interest is. And some people no, I'm happy with my diet. I'm not changing it. Or I see their diet and it's like, wow, that's great. Continue on, But you should be able to get a good plan with a naturopathic doctor, or at least the principles around it. Dietitians and nutritionists may be better at giving a meal plan and recipe menu planning. Mm-hmm. And if you want that level, that may be another choice to go with.
Thank you. That's helpful. Jen, let's do a live question.
So we have a participant who's written in that she's on a clinical trial where she may or may not be receiving an immunotherapy along with the standard of care. Right. And so her team is obviously very reluctant for her to take anything non-pharmacological, any natural therapies for symptom reduction for the chemo, because she might obviously be receiving immunotherapy. Are there any safe options that she could look at? Her biggest symptom is neuropathy.
So I would say acupuncture is an exceptionally good therapy for neuropathy that can be useful. It depends on the quality of the acupuncturist and their training. I wouldn't necessarily, not to bad talk the medical acupuncture that can be used, that is often, short-term treatments that are being prescribed maybe by physio or a chiropractor or a medical doctor. I think actually some NDs are very good in acupuncture, but then someone who is really trained in acupuncture in a traditional approach, either Chinese or Oriental medicine, often with a 4+ years of education in this, they treat the body as a system, and it's not just focus. So it's neuropathy can be helped with that. And I see that frequently with our patients, but I don't do acupuncture. I refer to the acupuncturist here, and he's very good. But Yeah, so it depends. But I think asking about that, and there are some, yeah, as far as natural agents, a lot of the therapies that I would use for neuropathy do actually interfere with chemotherapy. And so I steer away from them until the chemotherapy is done. There's a question popped up around reflexology. Absolutely worth trying. I think there's no harm in doing that. I think, what you don't want is to persistently go twice a week, till the end of time, right? You want to be able to see some improvement in the outcomes, in what you're feeling. So trying out a therapist, either acupuncture or reflexology, maybe massage even can be useful, is worthwhile. And time does heal these. Sometimes it takes a long time though, and not always. But you can maybe look at some of the biologically based therapies after treatment in some cases.
That's really helpful.
Yeah, we're going to move into a different direction right now. So,
okay,
what can you recommend in terms of temperature regulation? To provide some context around the question, the person asking the question is using CBD oil for neuropathy pain and also for heat ups, quote unquote, but is finding that she's using more CBD oil than she would like to use. She can manage the neuropathy with activity and rest, but is unable to regulate the temperature raises without the CBD oil. Is there something else she could try?
Yeah. So hot flashes, I think, as a temperature regulation that's probably fair to think about. So I'd mentioned a couple before, there can be the use of rhubarb extract or or black cohosh in certain cases. Acupuncture can be helpful in some cases. Diet, soy and flax, I've seen be helpful in terms of hot flashes before as well. So there's a variety of tools there. There's also just sort of, tricks in hygiene or whatever. There's time, which often helps regulate most things. But so those are some thoughts. The CBD, yeah, CBD I've seen be helpful in terms of sleep, anxiety, neuropathy, different things. Not so much neuropathy, sorry. But it can be expensive, and it can also, the doses can be difficult. So, it's finding the right mix for the person, and there are a variety of tools.
Okay.
Not a great full
Jen,
answer,
let's do a live question.
So a question about improving immunity. Are there natural ways to do so? So to improve your immunity that don't interfere, this is particularly around targeted therapies or immunotherapies, but maybe something that you could also speak to in general. So within the targeted therapy and immunotherapy, but also for patients in general who may just be on chemotherapy.
Yeah, so I have a bit of difficulty with that in terms of immunotherapy, because immunotherapy works by disinhibiting the immune system's effect, and it's very targeted and can be quite potent. So we don't want to interfere with that effect. But then the other aspect of immunotherapy is you can get side effects that are rather intense and can be risky. So you don't want to augment and boost an immune system response that may lead to a worse outcome, like pulmonitis or hepatitis, or something that like a significant side effect. So I'm cautious with immunotherapies, and I will use more anti-inflammatories in some cases where that, but they're not immune. I don't go for immune boosting. Not at this point for immunotherapies. With respect to chemotherapy, I think there is a role for natural immunotherapy. I mean, immunotherapy has been discovered by conventional oncology over the last decade or whatever. And I mean, this is a therapy that naturopathic doctors have been using for decades. Like, this is a therapy that we've always promoted, and is, and I think has a role to play. The immune system has a role to play in terms of identifying and destroying cancer cells that are in development, as well as those that are that are actually malignant. So, but it becomes a question of numbers and a question of how recognizable the cancer is to the immune system, because that's one of the characteristics that cancers achieve, is they become invisible in a sense, because they're part of our own tissue to the immune therapy. These new these new immunotherapies that are very targeted are effective in some cases at really uncloaking that. And I think there are things like mushrooms and mistletoe that actually have some real immune therapy effects that are natural and without the same intensity of side effects, because it's more boosting a response. Hyperthermia may have a role in this too, which is high heat application in the context of chemotherapy or radiation. Astragalus is another herb. You know, there's certain herbs that have immune supportive functions, especially for the innate immunity, which is the component of the immune system that is more directed against cancer cells. So those things that upregulate natural killer cells, or the T helper cells that are involved as well.
Okay, thank you. I have a question that was asked to me to ask you, and it's, I don't know if it's related or not, but they're asking about replacement bars, meals, and drinks. What are your thoughts around that? And I think it's a good question, because people just buy them OTC and there's no recommendation. Nobody's giving anybody any advice, and it's loaded with information of what it is in there. So what are your thoughts on that?
Yeah, so I would look at the ingredient list and look at the content. One of the best things to look at any ingredient list is the macronutrients. So you look at what's the fiber content, what's the carb content, what's the protein content, what's the fat content. And from the perspective of the fats, you're generally going to get a good profile. You're not going to get in these, most of these bars are really, you know, they're not going to be high in omega-6s or anything like that. You don't get like typically like a meat bar, right? They're all vegetable based. So so looking at the content of the sugar though, and the carbohydrates is important. So reading the carbohydrate component aspect of the ingredient list is telling. You want to look at the carbs, total carbs, you want to look at the sugars, and you want to look at the fibers. Essentially, the component that is glycemic is the carbs minus the fiber. And so you're going to get potentially, like if you've got, you know, 40 grams of carbs and there's 10 grams of fiber, it's 30 grams of usable sugar. So looking at that and looking at the proportion of sugar, if it's really sweet, high sugar content, and the proportion is, you know, 20-30%, it's probably too much. We're not going for a ketogenic type diet in this, but you're also not wanting to spike the blood sugar. So, you know, but by and large, most of these replacement bars are know that people are looking for a non-highly sweet bar, and it's got some protein, it's got some fiber, and so you're usually pretty safe. And with respect to meal replacements, things like Ensure, you know, there's cases where it's probably indicated, but it wouldn't be the drink of choice for gaining calories just outside. I'd rather like a, you know, high, maybe a smoothie with things where you add in not super sweet foods and some protein powder, especially whey protein powder would be one. I remember you asked about carrots before and juicing, so that's good. It reminded me of that. I don't like I think carrots are great, but you know, to drink like 16 ounces of carrot juice actually is detrimental, I would say. So that's going to cause a blood sugar spike, IGF-1 levels to go higher and all that. So I prefer people to not juice their foods, fruits and vegetables, but rather to eat them. You're not going to get a super, you know, special mix of enzymes and micronutrients by juicing all of the food. You're going to get, yes, you're going to get more of those, but you're also going to get the sugar stripped of the fiber and a higher glycemic effect, and potentially too much oxalic acid as well if you've got a lot of greens in there too. So anyways, yeah.
Okay, great. Do you have a live question, Jen, that you want to plug in now?
There was one just around the use of therapeutic touch as well. If you can speak to the role of therapeutic touch, or whether that's in your practice or something that a naturopathic doctor may refer to, or how patients could go about accessing that.
Yeah, so I mean, therapeutic touch, which is really being developed by nurses, is a very low contact, in fact, sometimes no contact, almost like Reiki, which is an energetic therapy, has been used, for a long time in hospitals, and some people really feel like they benefit from it, and therefore, if they feel they benefit from it, they do benefit from it. I don't use it. We don't refer to it necessarily here, but we've got some people that will refer out to. I think there's no harm in it, and if it feels good for you, then by all means, use it.
Okay.
And then
great.
actually just one more, Kathy, that was sort of circling back to the CBD oil, just to circle back to that quickly, and around any interactions with tamoxifen and CBD oil that you're aware of.
Oh yeah, good question. This has come up a bit with our nurse practitioner, who actually will prescribe medical cannabis, and the sense is that there's not a significant interaction, so it's usable if there's a real benefit. And so yeah, I think it's safe, but it's a good question because cannabis can alter metabolism.
Okay. Jen, do I have time for one more question? It could be a lengthy answer.
You're good. We've got
Okay.
about just over 10 minutes left. So
Okay.
we'll try to
Okay.
add a few more in here.
Okay, great. So the next question reads, could you provide information to speak to specific research articles outlining the benefit of a detoxification protocol post-explant? Also, the recommended length for a detox based on how long someone has had an implant in.
Oh
Is
boy.
that clear? That's a loaded one, isn't it?
No, it's a good question, and it's a question that we get. It's great, but difficult to answer, because I think the idea of detoxification is one that lots of people approach, and they get this specific formula of things that's going to help them detox and then be clear. I don't think that's not the way that I approach it. I think there are herbs and medicines that can enable more effective detoxification, where, by upregulating maybe bile dumping from the liver, or, ensuring that the metabolizing, the conjugates that can attach to some toxins are sufficiently present to help with that, to eliminate them from the body. Or in the cases where maybe there's heavy metals, that's a real part of the picture, then there can be detoxification protocols for that. Often requires some testing to look at, is this really part of the picture or not? Time helps detox, but then also the healthy function of the organs involved in detoxification is what I try to achieve regardless. So that means bowels, that someone is eliminating well, having regular bowel movements, not constipated, and that it's formed well, all those. So, your NDs do like to ask about poo.
Yes.
And that's good. It tells us a lot. So a healthy functioning GI and elimination is really foundational for health. It is. And so there's that. And then the other things are, is the pee dark in color? Does it smell? These things are indications in terms of the functioning of the kidney, but more hydration of the person. And is there bad breath? That may be a sign of something. Is there bloating? Is there some potential for intestinal bacterial overgrowth? There's a lot of aspects on this. Also, use of saunas can be helpful, actually, as a detox. The skin is a very effective detoxer. The lungs also help to detox. So, people are exercising more, are pushing this out of their body. So you want your body to be a good filter, but get rid of the stuff that's not good quickly. I don't do detox with chemotherapy because we don't want to eliminate it super fast, right? We want it to be there for the time that it's supposed to be. And then after that, yeah, I'll consider detox programs for that, but it's not like do the 12-day certain thing. Intermittent fasting, there's a whole discussion around fasting too, and what benefits there can be from that. I think there are some uses there, but yeah, does that answer that well enough?
Yeah. How long would you wait after chemotherapy to do detox?
If it seems like it's an important thing, it's interesting. Like the cisplatin, the platinum agents, I would actually avoid because they may have some long-term benefits by residing in the tissue to reduce risk of, say, ovarian cancer recurrence. So it would be a little bit of a graded question depending, but after something like ACT, it would just be a few weeks.
Oh, okay. That's soon after. Okay. All right. Jen, do you have any more floating questions?
I do. So we have two more, which I think we can fit in. So a question around whether or not you think that complementary therapy and integrative medicine should be included. At what point, sorry, I should rephrase that. At what point do you think that should be included in the care of someone with cancer? And is this something that breast cancer patients should wait until they're done their treatments for, or should they be connecting with someone in the complementary therapy field prior to starting some of those treatments or during those treatments? Is there an optimal time to start?
What a great question. So I would say that, yeah, it's for me, I like to see people right at the outset. I think there's benefits in terms of pre-biopsy even and pre-surgery and for recovery from that. I feel very comfortable interacting with the different points of transition and care. And I think it's helpful for people to have a sense of what they can do. But I guess in cases where you're feeling like it's really more of an alternative approach, then I would consider waiting till after the therapy is done. Don't interfere. If you feel like the practitioner is not knowledgeable enough, or you're not confident that this is not going to interact, then you may want to wait. But I think with a practitioner that's knowledgeable in the area, you get support through each of the stages more effectively.
And then just as a follow-up to that, I guess, is there a role for purely alternative medicine in the treatment of breast cancer? And can you speak a little bit more to that?
Right. Yeah. So this is a question that comes up in a small number of our patients who are really just wanting to avoid anything, including surgery. And so it's a discussion that is very tuned to what they're dealing with and what their condition is. Someone with an early stage breast cancer who is wanting to avoid surgery and feels like an alternative care plan can help them really get through this and avoid and cure them of the disease. I'm very uncomfortable in those situations. I will give some guidance around things like food and other things, but I won't recommend more aggressive therapies because I don't think there is a substitute in that case. And like for surgery, if you've got a case of DCIS where there's some watchful waiting potential and you've got an oncologist that's willing to follow up on it, or a radiologist that's willing to follow up on this, then possibly. But in the case of a curable disease, then I don't think there is an alternative. No. In cases where people have more advanced disease, have done a series of chemotherapy in the past, have had some really bad side effects with it, and they want to do a more alternative approach in a sense to management of their disease, then it's a different discussion. And then it's working with the patient where they're at and looking at how they're responding and what are the symptoms that they're dealing with. Can I effectively actually provide a meaningful improvement on that, or do they need to be in with a palliative care team, or are they really going to benefit from the chemotherapy in terms of their quality of life as well as their longevity? So there's so much variability. But I mean, the good thing about breast cancer now is it's much more manageable than it used to be. There's so many more options in terms of targeted therapies and even just anti-hormonal therapies and things that you can graduate from one treatment to another. And so it becomes more of a management issue. And in that, quality of life really is important. So I think the integrative approach is absolutely the approach to go with. And yeah, it's a promising area, and we're going to see more improvements in this for sure.
Well, and I was going to say that's a sort of great place to maybe wrap it up. We do have, but there is one follow-up question just regarding
Sure.
the detox, and it's around heavy metals. So if we can address that in like 1 or 2 minutes. And detoxing for heavy metals during radiation, is that okay, or is that something that should wait until those treatments are done? And when would you pick that back up again?
I would not do it during radiation therapy. Like heavy metal detox is not a quick thing. It takes a longer time, and so yeah, the treatments I would probably interfere potentially with the radiation, and I'd rather just get through the radiation rather than that, because you can, through detox, you can create a little bit of negative side effects from it as a result too. So I wouldn't lay it on top of that, no.
Well, and I think that that's perfectly timed. It's stuck within the 1 minute time frame there. So thank you for sharing so much knowledge. I was taking notes furiously, and I know Kathy, you had a ton of follow-up questions as well. A lot of engagement from participants. So Dr. Seely, thank you so much for your time. That really concludes our time for today's session. And thank you for the participants for your great questions as well. And again, Dr. Seely, for sharing all of your knowledge with us on so many topics that sort of fit within the ND space, which seem to cover everything. So thank you.
Thank you so much.
And personally, I want to thank you, Dr. Seely, about your answer to dark chocolate and red wine. Thank you.
Great. Glad to have that question in there. Thank you for that. And for the excellent questions, really, really great questions from the audience, and you guys. So thanks for all of that. And yeah, it's been hopefully it's been useful for people for sure.
I'm sure.
I would say so. I just want to say thanks again for our to our sponsors for today. So our gold sponsor Viatris, our silver sponsors Novartis and Roche, our bronze sponsors AstraZeneca, Ontario Trillium Foundation, Knight, and Pfizer Oncology. We will be sharing a short survey with everyone who participated, and as this webinar was recorded, we will also share the link back where you can view the recording if you want to re-listen, or there was something you wanted to catch again that you didn't have the chance to write down. So we'll make sure that we share that back with everyone. Thanks everyone for joining us. Again, Dr. Seely and Kathy, thank you for hosting. Have a wonderful day.
Thank you.
Thanks. Bye-bye.
Bye.
Bye.